Thank you for watching the Environmental Physiology Journal Club Network series. My name is Yuri Hosokawa from Waseda University in Japan, and today I'll be sharing with you a brief overview of a paper titled Tar-Persisted Cooling as a Method of Whole Body Cooling in Hyperthermic Individuals, which was published in 2017. This study was conducted with the hope to help provide clinicians who work in the sports settings validated options to treat exertional heat stroke patients in pre-hospital setting. It has been long established that survival from exertional heat stroke relies on rapid whole body cooling to reduce the duration of excess hyperthermia above 40.5 degrees Celsius. Current consensus is that reduction of internal body temperature below 39 degrees Celsius within 30 minutes of collapse is the goal clinicians should aim to achieve. This in terms of rate of cooling is minimum of 0.15 degrees C per minute. In order to meet this criteria, a whole body cold water immersion has been considered a gold standard, and therefore it is expected that when the risk of exertional heat stroke is high, cold water immersion tubs are set up on the sporting field. However, spatial, facility, or financial limitations and other event-specific logistics may hinder clinicians from implementing this. For example, here's a photo of a 150-gallon or 568 liters tub. If we were to fill this up for cold water immersion by 2/3, it would contain about 380 liters of water, which makes it impossible to move it around, and therefore we need to be mindful that these are stationary setups. When covering a large area, such as entire athletic complex or marathon races, this becomes an issue because in some circumstances, patient may be collapsed in a remote location far away from the station immersion tub. Therefore, having a portable option as a backup would help clinicians significantly. When cold water immersion is not feasible, tar-persisted cooling or TACO method has been proposed where water and ice is poured on a patient who's lying on a waterproof tarp that is held by 3 to 4 individuals so that the ice water is contained and clinicians can continue to cool the patient, just like the pictures to the right. At the time of our study, one study to our knowledge have investigated the cooling rate of TACO method using 40 gallons of 2 degrees cold water, which resulted in cooling rate of 0.14 degrees per minute. In our study, instead of specifying the water temperature, we chose to use 38 liters of ice and 76 liters of water, which was equivalent to one 10-gallon cooler of ice and two 10-gallon coolers of water. We hope that by specifying the amount instead of the temperature would make it more practical for clinicians to follow. In this study, we also aimed to examine if sex and body mass was associated with their cooling rates. The study method was very simple. Participants were asked to exercise for up to 60 minutes in a climatic chamber for an aim to increase their rectal body temperature as high as 39.9 degrees Celsius. Once the exercise protocol was completed, 3 researchers set up the tarp to initiate TACO inside the climatic chamber and began cooling until the patient's rectal temperature was 38.25 degrees Celsius. In our study setup, the resulting average water temperature using the 10-gallon ice and 20-gallon water was 9.2 degrees Celsius. Before I share the results, I would like to note a common ethical delimitation we have in studies related to exertional heat stroke. That is, we cannot intentionally induce exertional heat stroke to study about treatment efficacy. That being said, like many other studies, we used exercise-induced hyperthermia model to study about the cooling rate of TACO. Having this type of lab study is important because although it is not a real scenario, by having these type of pre-study in lab can serve as the basis to conduct observational field study in real patients in the future. Moving on to the results. You can see the participant characteristics in the upper right-hand table. First, time to initiate cooling using TACO was on average 3.4 minutes, which is an important piece of information for clinicians as they can make decision about whether it would be faster to go to the patient and initiate tackle cooling on site, or go to the patient and transport the patient back to the cold water immersion tub. The average cooling rate was 0.17 degrees Celsius with no statistical difference between male and female. You can see that there was quite a range in body size of individuals who participated in the study. However, there was no statistical association between body mass on cooling rate using tackle. Overall, the study findings support the use of tackle as an alternative exertional heat stroke treatment method when cold water immersion is not feasible. When looking at individual variances, it should be noted that participant with the largest body mass and the lowest body fat percentage had a cooling rate of 0.20 degrees per minute, and a total cooling time to 38.25 was 7.8 minutes. While participants with smallest body mass and the largest body fat percentage in our study, which both happened to be in female participants, had cooling rates of 0.09 degrees per minute, and total cooling time was 30.5 minutes and 10.85 minutes, respectively. These cooling rate values may have been influenced by the initial rectal temperature, as the male participant in this example here had much higher starting rectal temperature than these two females, creating much greater temperature gradient. Also, although the cooling rate in these female participants was slower, it still fell an acceptable cooling rate, which is defined as anywhere between 0.08 to 0.15 degrees Celsius per minute for exertional heat stroke treatment, as defined by previous literature. So in conclusion, while tackle should not replace cold water immersion, clinical implications of our study are as follows. First, our study suggests that the sum of average time to prepare the TARP assisted cooling modality and average cooling time was well under the 30-minute critical time to treat patients with exertional heat stroke, providing an option for clinicians. Second, 20 gallons of water, 10 gallons of ice, and a TARP, as shown on this slide, with a minimum requirement of 3 rescuers used in the study protocol, ensures feasibility in the field settings where resources may be limited to prepare a cold water immersion tub. This is the end of my presentation. Thank you for watching.